Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, it is Mr. Edwards, correct?
Yes, that's correct, but you can call me Josh.
Okay, Josh. We are here today for me to conduct an occupational therapy assessment to review the equipment needs in your home to support you in managing transfers more independently. How does that sound?
That sounds great.
Let's first take a look at your accident. I see here that you were involved in a traffic accident about 5 months ago.
Yes, and it was quite a serious one. I sustained significant injuries to my left leg, particularly my ankle.
Yes, quite serious, John. You have already undergone several reconstructive surgeries, is that correct?
Yes, that is quite correct. I've been through a few surgeries already, but I'm still waiting on further surgery, which they tell me will be done in the next few months.
So you are still non-weight bearing on your left leg, and I see you're still using crutches provided by the hospital.
I guess you could put it that way. It has been quite a struggle managing the crutches. Also, because of the significant swelling in my left ankle, I've been advised to keep my leg elevated much of the day. So, in general, not a lot of moving around for me.
I see. So, as I said, John, I'm here today to review the equipment needs to help support you in managing transfers. You currently need physical assistance to get on and off the bed as well as chairs. Is that right?
Yes, that's right. I'm constantly having to bother my wife or teenage son to help me. I hate being such a bother. So sometimes I end up staying in bed for much of the day, to keep out of the way. I mean, I do sometimes ask my son to help me sit on the couch.
How is that for you? Any pain while sitting on the couch?
No, not while sitting on the couch, but as the sofa is low, my son has to pull me to standing before I can use my crutches. I often experience spinal and neck pain after sitting on the sofa, and I think him pulling me is part of the reason why. Also, when I sit on the couch, I have to sit along the length of the couch, so my neck is always twisted if I try to watch the TV or talk with anyone.
I think we can definitely help with that. I'm going to recommend a more suitable chair that I think would be of significant benefit. The chair has a rise function that will enable you to manage an independent sit-to-stand transfer, which will reduce your dependency on your family, as well as the risk of injury from the technique you are currently using to stand up from the couch.
Sounds interesting. What about my legs? How will I keep them elevated?
The chair also has a leg rest elevation function, so it will help you to sit in an aligned position with your legs elevated. This will help you to reduce the twisted neck you spoke about. We can put the chair anywhere you would like, but I think it would be a good idea to put it here in the main lounge to reduce your isolation and the amount of time you spend in the bedroom. How does that sound?
That sounds fantastic. So what do we do next? How do I go about getting this chair?
We will set up a joint visit to a local seating provider who can offer you a variety of options to maximise choice and value. We will make sure that you get a chair that meets your clinical needs, as well as your choices regarding fabrics and colours. I mean, the chair will be in your main lounge for at least a few months, if not more.
Yes, that will make my wife happy.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase.
Hello, it's nice to see you, Mrs. Johnson. And who do we have here?
Hi, this is Alex.
So I see that Alex is 1 month old, is that right?
Yes, that's right, 1 month.
Before we get into what may be going on with Alex, let's go through your medical history a bit. Was your pregnancy with Alex complicated?
No, not at all. Alex was born after a full-term pregnancy with no complications or anything like that. He weighed just under 3 kilos at birth, 2.94 to be exact.
A very good birth weight. And what about your family and family history of chronic disease?
Yes, let me think. Hypertension and diabetes are prevalent on both sides of the family, but I'm not sure how far back it goes. I don't know much about my husband's grandparents.
Okay. So I understand that you have a number of concerns about little Alex, Mrs. Johnson.
Yes, I do. Do you see how yellow Alex's eyes are? They've gotten worse over the last couple of days. I mean, I know jaundice is pretty common in newborns, but it doesn't usually go on for this long, does it? And it isn't supposed to get worse, is it? Also, even for a newborn, Alex has quite an irregular sleep schedule. He frequently gets his days and nights mixed up.
Okay, well, the irregular sleep pattern is somewhat normal, but I am concerned by the yellow colour of his eyes, particularly if it's getting worse. Neonatal jaundice is common and usually does not require treatment, but the presence of jaundice after the first couple of weeks of life is worrying. I'm going to evaluate Alex for cholestasis. He showed increased levels for bilirubin in his last visit 2 weeks ago, but we will need to do further testing to assess the direct bilirubin concentration.
What is that? Is it serious?
Cholestasis is a condition in which bile cannot go from the liver to the duodenum. This causes a waste product in the blood, bilirubin, to accumulate in the bloodstream. It is a likely explanation for the colour of his eyes. In terms of seriousness, that all depends on the cause of the cholestasis. The two most common causes are idiopathic neonatal hepatitis and biliary atresia. But we will need to do more testing before we can get to a definitive diagnosis.
Okay. There is one more thing, the matter of the broken leg.
That's quite alarming. How did that happen? Did he fall?
No, nothing like that. I was changing his diaper and he suddenly started screaming as I was pulling his bottom up to slide the diaper underneath. It was so frightening. I mean, Alex is my second child and nothing like this ever happened with my firstborn.
Alex's temperature, respirations and heart rate are all within normal limits, but he does appear to be somewhat irritable. Also, his spleen and liver feel enlarged. I'm going to order an ultrasonography examination of the liver.
Oh my, what will happen after that?
It depends, but we might have to do a liver biopsy to further assess the damage and enlargement of the liver and spleen. During this time, I'm going to bring a paediatric hepatologist onto the team to help with Alex's care. Paediatric hepatologists are doctors that are specially trained in the diagnosis and management of all types of childhood liver disease. I'm still concerned about the broken leg. It could be related to problems in the liver or a lack of vitamin D concentration. We will need to check that as well.
Yes, it's so difficult to make him comfortable and get him to sleep with the broken leg. It causes him too much pain. I mean, I can't imagine.
Part B. In this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio.
Now look at question 25. You hear a morning briefing on a ward. Now read the question.
Hello all. So, let's get started. Felicity, can you start off this morning's briefing?
Yes, I certainly can. So, first up, we have a 99-year-old woman with a history of high blood pressure, congestive heart failure and knee osteoarthritis. She is presenting with abdominal pain increasing over 5 days, along with obstipation in the last day. Exam showed abdominal distension, hypoactive bowel sound and no mass found.
Okay, so next steps?
Based on the symptoms and physical exam, an abdominal CT scan and volume repletion are the next steps.
Question 26. You hear a trainee nurse asking a mentor for advice. Now read the question.
Hello, Jane. I have a patient I would like to discuss with you.
Sure, tell me what you have.
I have a 32-month-old boy who was brought to the outpatient paediatric clinic because of weakness and failure to thrive. He is 3 kilograms below the expected weight for his age, and physical examination revealed a febrile, fussy child who does not like to be touched. According to his mother, he doesn't have diarrhea, but his appetite is poor. I mean, I know where the evidence is pointing me, but...
What working differential diagnosis are you considering for the child?
The mother and the child have never been tested for HIV, so that is a possibility, along with TB, malnutrition from lack of food, enteric parasitic infections, or combinations of these etiologies.
I agree with you. So what is your next course of action?
Question 27. You hear a nurse talking to another nurse about the discharge of a patient. Now read the question.
Jack, can I speak to you for a moment?
Yes, what's on your mind?
I noticed you seem to be a bit hostile towards the HIV-infected mother who is about to be discharged with her baby boy. You should be focused on teaching your patient some important counselling messages before she leaves, but instead it seems to be difficult for you to have a conversation with her.
I know, but I just can't stop thinking that women like her should never have children. She put her poor infant in possible danger because of her foolishness.
Remember, we are here to protect our patients' rights, not judge them for past choices. Also, think about how you would feel if you were in the patient's shoes or had a close relative with HIV. Would you want them to be discriminated against?
Question 28. You hear a nurse talking about a new education program for parents. Now read the question.
Hello, everyone. Today, Kathy from the Neonatal Intensive Care Unit is going to talk about a new education program for parents that is being developed.
Thank you for allowing me to talk about this new program. What we are aiming to do is develop a teaching plan for parents of premature babies who are nearly ready for discharge. We have to take into account that these infants might have any number of physical needs upon discharge, including special feeding instructions, apnea monitors, temperature instability, among others, and that the parents will be anxious, tired, and possibly in pain in the case of post-caesarean mothers. I am here to get your feedback on 3 priority areas we have identified: risk for abnormal body temperature fluctuations, risk for ineffective breathing patterns, and
Question 29. You hear a doctor in the A&E discussing a case with a nurse. Now read the question.
any luck getting Mr. Walker to agree to contact his daughter?
No, Dr. Avery. He insists on not bothering her at her job, but he doesn't seem to know anything about his condition. He told me he takes a blue pill for his high blood in the morning and 2 pink pills at dinner. I mean, he nodded when I explained to him that he should elevate his left foot and apply ice packs, but
Who knows if he actually understood you, or if he will tell his daughter what happened. Do you think that the friend that followed the ambulance here will be any help?
no, I don't think so. I mean, she seems willing and able to get him home, but she also has no idea of what medications he's on. I really think we should wait to see if we can contact the daughter.
Question 30. You hear a hospice nurse explaining intake protocol for new patients. Now read the question.
Over the next 48 hours, I will have a series of meetings with you to explain the options and assist in decision-making choices for your loved ones. Other team members include the hospital palliative care team, the nursing staff, the physician, the chaplain, and the social worker, all of whom will also take part in these meetings. The first meeting will cover prognosis, code status, and treatment options, and the second meeting will cover nutrition, hydration, and treatment of any concurrent illnesses. Then we will have a meeting discussing palliative care and hospice, as well as the scope of available resources. The fourth and final meeting will introduce the concept of de-escalating care, initiation of comfort measures, and the involvement of family and friends. You will have the opportunity to ask questions at each session. We will also
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36.
You hear an interview about a career development in occupational therapy. You now have 90 seconds to read questions 31 to 36.
Hello, Mrs. Craig. Mrs. Craig is an honorary fellow at Bridgemont University and is a regular contributor to the official journal of the College of Occupational Therapists. We are pleased to have you here today to talk about career development in occupational therapy. So, please start off by giving us a little bit of history about the topic.
Yes, thank you, James, for the introduction. I am very happy to be here to talk about a topic that is near and dear to my heart. Until about a decade ago, occupational therapists in the United Kingdom were fortunate in that demand for therapists exceeded supply. There was little need to think of career development since posts and promotion aspects were plentiful.
I understand that you're implying that the situation has changed over the years. Is that correct?
Yes, and that's quite correct. Today, occupational therapists face the same challenges in finding a first post and developing their careers as others do. Fortunately, many of the attributes that make for effective practitioners in the field of occupational therapy are also valuable in professional development. In particular, flexibility, creativity, problem-solving, and lateral thinking.
What have occupational therapists done with these areas of strength?
Occupational therapists have combined these strengths with entrepreneurship to move the profession beyond familiar areas, such as the National Health Service and social services. We're starting to see therapists work in a much wider variety of posts.
Quite interesting. What role has the College of Occupational Therapists taken to encourage this development?
The College of Occupational Therapists has lobbied quite a bit for a change in how occupational therapists are educated. As a result, universities have started to prepare graduates for the future through providing role-emerging placements as well as including courses on entrepreneurship in the standard curriculum. There is evidence that this change in the curriculum has encouraged new and developing areas of practice in the field, such as low vision and driving. This is a wonderful development because just as our profession has become more diverse in the UK, employment patterns and career paths have become less predictable, which means therapists need to be prepared to be more proactive and flexible in developing their own career paths.
What exactly do you mean by flexibility?
I mean that graduates seeking a first post need to be willing to start where opportunities occur and to work to create a path towards their ultimate goal instead of holding out for that perfect opportunity. A short-term post in occupational therapy or a related area can provide both experience and an employment reference. This can be combined with postgraduate study to widen knowledge in a preferred area and enhance employability. In addition, working in the voluntary or private sector provides a different perspective that can be applied to work in the public sector. In the end, each therapist has to make choices that will move him or her in the direction of the next career goal, and also be open to discover new areas in the field not previously considered.
What kind of career path do occupational therapists with a bit of experience tend to pursue?
Once experience is gained, most therapists pursue a clinical career, but other avenues also exist, for example, in management, education, private practice, and research. There are now more opportunities to combine roles in lecturer, practitioner, or clinical researcher posts and to pursue private practice on a part-time basis. It is becoming more and more common for therapists to work for different employers and to move between the public, private, and voluntary sectors.
So what role does continuing professional development play in the career of a therapist?
Well, continuing professional development is at the heart of an occupational therapy career. It is the link between a current post and future aspirations, and it can help to maintain a focus on the profession while in a non-occupational therapy post. Professional development, along with active participation in the professional association and keeping up to date by reading research journals, can be a lifeline in an uncertain future.
So, I see we have a number of people with questions. We will now give the audience the chance to.
Now look at Extract 2. Questions 37 to 42.
You hear a radiologist talk about the latest trends in her field. You now have 90 seconds to read questions 37 to 42.
Thank you for the warm welcome. My name is Dr. Kelly Preston, and I'm here today to talk about the latest trends in the field of radiology. As we all know, for the past few years, information technology and digital solutions have exploded in the field of radiology. It's such a hot topic that the Radiological Society of North America recently announced that the focus of their next annual conference will be exclusively imaging information technology solutions and will not include other devices as in previous years. This pivot to technology in radiology is mostly driven by the current landscape. There is a massive demand for always-on and mobile-friendly solutions in all areas of our lives, even in the medical field. This may seem like a drawback of technology, but the medical field will need to figure out ways to take advantage of this reality. Another driver is the fast pace of innovation and advancement of available technologies. In just a few years, machine learning and artificial intelligence have made it possible to automate nearly anything in our lives, from driving to radiological procedures. The first trend that I'm going to expand on is, in fact, artificial intelligence. 2 years ago, AI started to show up in demonstrations, wowing all of us. But it was last year when AI's real-world impact became evident, when machine learning solutions for detecting biomarkers in stroke patients became a reality. Experts are also predicting that AI will lead to improvements in image acquisition by hastening MRI imaging time, enhancing CT resolution, and enabling dose reduction with PET/CT. Another particularly exciting development that AI technology could bring is a move toward a greater ability to identify changes over time in imaging studies. This advancement could be particularly helpful in mammography studies, where AI can recognize disease progression early, resulting in better outcomes for patients. AI is a trend that will definitely continue to have an impact on the future of radiology. Another example of technology making its mark is big data. Massive databases of information have been collected over the years, and now machines, more specifically machine learning, are poring over it, processing it, organizing it, and most importantly, analyzing it to find relevant insights. These deep learning solutions are being used to improve existing operations, treatments, and to discover new opportunities. For example, huge collections of data combined with a machine learning system can help identify better and more accurate ways to diagnose patients. Now, for a trend that doesn't involve technology. Radiologists are more necessary than ever. Yes, I said it. We are more necessary than ever, despite the worries that we may have about AI and machines replacing us. With some of the workload being automated by technology, radiologists are needed for clinical care and patient interactions. Each radiologist should serve as a point of contact for patients, allowing for better and more down-to-earth explanations of various situations, treatments, and actions that other providers may not be able to provide. In fact, radiologists will become an integral part of a care team as patients continue to push for more personalised time with their providers, which may require radiologists to reimagine imaging workflows that aren't compatible with offering more face time to patients. It will take time to make these changes, but they will be beneficial for our patients and the future of the field of radiology. Another technology-free trend is the growth of interventional radiology and its divergence from diagnostic radiology. As these two specialties continue to diverge, we will have to continue to develop different residency curricula, different clinic emphasis, and procedural work will be done less and less by diagnostic radiologists. For many years, techniques of interventional radiology were only used to make cardiovascular procedures less invasive, but in recent years, these techniques are being used in neurology, gastroenterology, and urology. Last but not least in this list of trends are the challenges that the field of radiology faces. One of the biggest stumbling blocks that radiologists continue to face is convincing referring clinicians that we, the radiologists, are the experts with imaging and should be able to communicate directly with patients about the results of imaging. It is often difficult for referring physicians to cede control to other specialists like radiologists. Let's hope that the trend for next year include increased communication with patients.
That is the end of Part C. You now have 2 minutes to check your answers.